Well, good morning all, and welcome to today's Medical Grand Rounds. I am here in Southern Auditorium at Providence St. Vincent Medical Center, and we will start with just a couple of reminders and then introductions. Next week, we will have a one-week break from Grand Rounds to enjoy the fall and holiday, so please do not look for us next week. We'll then be resuming Grand Rounds on December 1st, and we'll hear a talk about type 1 diabetes, which will be a joint presentation from Dr. Liz Stevens, as well as Maureen Sprague and Brianna Potticini. And now just a few logistics. We're very excited to be hosting our lectureship live on both Tuesday and Wednesday this week. So as mentioned, we're here at St. Vincent today, and our speaker will be at Providence, Portland on Wednesday morning from 8 to 9 a.m. in the auditorium. This is also projected on the Teams live platform, and you can earn CME credit for viewing in any of those formats or for watching a recording, which is available at the same link as the invite for Grand Rounds. I'll be monitoring questions on the Teams live platform throughout the presentation, so please feel free to go ahead and pose any comments or questions, which I will mostly hold for the end as time allows. And now, on to more exciting things. I am particularly excited to share with everyone today the 2022 Dr. Huldrych Kammer Lectureship. Many of you know, but for those who do not, Dr. Huldrych Kammer touched countless lives as a role model physician, a pioneering endocrinologist, a gifted teacher, and a lifelong learner. Dr. Kammer served as Associate Director of the Internal Medicine Residency Program at Providence Portland Medical Center for 30 years and was also Professor of Medicine at Oregon Health and Science University. Over the decades, Dr. Kammer touched countless lives of residents, fellows, medical students who all benefited from his love of teaching and his passion for personal lifelong scholarship. He also was admired as a mentor to fellow practicing physicians. He published seminal work and contributed greatly to the modern era of endocrinology. It is in his honor that I am delighted to introduce today's speaker for this year's Huldrych Kammer Endocrinology Lecture. Dr. Mary Samuels is a professor of medicine at OHSU. She graduated from the University of Chicago and Harvard Medical School and completed residency and fellowship training at the University of Colorado. Dr. Samuels is Program Director of the OHSU Clinical and Translational Research Center and has been a member of the American Thyroid Association Executive Board. She served on editorial boards of prominent endocrinology journals, as well as the NIH General Clinical Research Center and Clinical and Translational Science Award review committees. Dr. Samuels' research focus is on neurocognitive and metabolic effects of altered thyroid status. Thank you so much for joining us today, Dr. Samuels.
Thank you, Laura, for that lovely introduction. And it's a true honor and a pleasure to be here to present this year's Kammer Memorial Endocrinology Lecture on a topic near and dear to my heart, which is mild thyroid dysfunction. Does it matter? So let's start with a few definitions of what I mean by mild thyroid dysfunction. And that is illustrated on this slide. It comes in two flavors: mild, or what we often call subclinical hypothyroidism, which is defined as an isolated elevated TSH with T4 and T3, the thyroid hormones, normal, or mild, or what we often call subclinical hyperthyroidism, an isolated low or suppressed TSH, again with normal T4 and T3 levels. So how does this happen and how can we explain it? Well, that's shown here on the left-hand side of the slide with the classic hypothalamic pituitary thyroid axis that we all know about. And as you all know, TSH here, secreted by the pituitary gland, plays a central role in this axis. And so what happens in mild hypothyroidism is that for whatever reason, the thyroid gland starts making not quite enough thyroid hormone, primarily T4. And that can be for whatever reason. It's usually Hashimoto's disease, but it can be from other reasons as well. And so if we measure the T4 and the T3, they are still in the broad population reference range for the laboratory. But they have snuck down a little bit below that patient's set point for thyroid action, which is genetically determined and which is much more tightly regulated than the broad population range. So for example, somebody's T4 may normally be 1.2 and it goes down to 1.0, which is still in the reference range. And so we wouldn't pick it up, but the pituitary gland picks it up, senses that, and increases its production of TSH to try and stimulate that failing thyroid gland. Conversely, if for whatever reason the thyroid gland starts to make a little bit too much T4 or T3, and again, this can be for all sorts of reasons, Graves' disease and so on, we're still measuring this in the broad population normal range, but the pituitary gland senses this, suppresses its production of TSH to try and settle down the thyroid gland. So these are real entities. They're not just laboratory abnormalities. And I'm going to spend most of my talk on the first entity, mild or subclinical hypothyroidism, and then just touch on mild or subclinical hyperthyroidism near the end of the talk. And that's because mild hypothyroidism is very common. There's a lot more literature on it. It's often kind of more of a conundrum as to whether to treat it. And so I'll spend most of my time on that. Okay, so the first question for me to try and answer for you is, why do we care? Why is mild or subclinical hypothyroidism important? Well, for one thing, it's extremely common. It occurs in up to 20% of older women, somewhat less common in older men, but still common. And so you will see this almost every day in your clinic. And it may have clinical consequences. It's not just a biochemical abnormality, but they're often not the consequences that patients are concerned about. And I will go into a lot of detail on what patients are worried about versus what endocrinologists are worried about with this entity. And then finally, from a public health perspective, levothyroxine, or LT4, is the most commonly prescribed drug in the US and it is overprescribed, so we often accidentally induce hyperthyroidism in our patients, and that does have clinical consequences. So let's go into a little bit more detail about the epidemiology of this, of LT4 treatment and overtreatment. So thyroid hormone use doubled in the United States between 1997 and 2016, and that's illustrated on this graph, such that by 2016, almost 8% of the, is still working? Can you still hear me? Okay, there we go. About 8% of the US adult population was receiving levothyroxine, and that's a huge number. And the reasons that we're treating so many people with hypothyroidism is that they have very mild abnormalities in TSH, which I just mentioned are quite common. So this is another recent study where they looked at what the initial TSH levels were before patients were started on levothyroxine. And the mean initial TSH over time in this study was only 5. And you'll recall that the upper limit of normal in most of our assays is 4. So this is barely elevated at all. So we are primarily treating mild hypothyroidism. 60% of the cases here over the years of this study, shown in this kind of middle grayish blue bar, had subclinical or mild hypothyroidism, not overt hypothyroidism. And most of the time the TSH was less than 10. And remember that cutoff, because that's often the cutoff we use for treating based on some data I'll show you later. And what's even more concerning, shown on the upper part of this graph, is that about 30% of patients over this time period had normal initial TSH levels and were started on levothyroxine. Now, occasionally there's a reason to do that, but in fact, that's pretty rare. And so my guess is that most of these patients are being inappropriately treated. Does that have consequences? Well, what happens to these people who start on levothyroxine? It turns out that over 90% of them remain on LT4 for at least 5 years. So this kind of ends up being a permanent medication. And well, so, you know, what's the big deal about that? Levothyroxine is usually inexpensive, usually safe. But in addition to the inconvenience and the cost of being on this medication and requiring monitoring and prescriptions and all that, it turns out that a large proportion of these patients are actually inadvertently overtreated, and that's they have a low or a suppressed TSH. And this is another article, and it graphs the lower suppressed TSHs according to age range. And you can see that a significant number of people, especially the older population, has either a low TSH or a completely suppressed TSH on levothyroxine. And this is especially problematic in older patients because they are at higher risk for adverse consequences. So this is an important public health issue. And I hope that that helps convince you why we should care about this. Okay, let's turn now to clinical considerations. I'm going to present a case here that I saw a number of years ago. She's a 47-year-old woman with a long history of multiple symptoms. Her main symptoms were fatigue, depression, what she called brain fog. I'll talk more about that in a minute, and weight fluctuations. She was thought to have Hashimoto's disease a year earlier due to multiple symptoms and a mildly elevated TSH documented by her PCP, but she did not return at that time for follow-up. So she came to my clinic and I evaluated her. At that time, her past medical history was significant for anxiety and depression. She was not taking any medications. On physical exam, she was fatigue appearing but had no obvious signs of hypothyroidism. She did, however, have a mildly enlarged 30-gram and firm thyroid gland, and that is classic for Hashimoto's or autoimmune hypothyroidism. Her TSH a year earlier by her PCP was mildly elevated at 10.3. Repeat in my clinic was 12. And her free T4 was normal, confirming mild or subclinical hypothyroidism. So as I'm seeing her in clinic, what are her priorities? Well, they're pretty obvious and pretty appropriate. They are, she wants to feel better and she wants to lose weight. I have some of the same priorities, but also some other ones. First of all, of course, I want to help her feel better. But I'm also thinking about clinical effects of mild hypothyroidism that could harm her in the long run, but which she may not be aware of because they're not causing symptoms. And then finally, my third priority is that I need to explain to her that many of her symptoms may not be related to this mild abnormality in thyroid function and therefore may not get a lot better with LT4. So this leads me to my first caveat. I've sprinkled 3 of them through this talk, and here's the first one. And that is that temporary elevations in TSH are common. And that is shown in this study here on the left-hand side of the slide, but also in a lot of other studies since then. And mild TSH elevations, especially if it's only up to 10, if you don't treat it, but you just wait, up to 50% of those just resolve on their own over time. Why is that? Well, we don't usually know. It could be a little bit of a temporary inflammation in the thyroid gland called thyroiditis. It could be that the patient is recovering from any one of a variety of non-thyroidal illness issues where the non-thyroidal illness temporarily suppresses the TSH, and then as you recover, there's a little bit of a rebound. There might be some natural variation in immune activity directed to the thyroid gland, but for whatever reason, what this shows us is that it's almost always best to repeat the TSH before starting LT4, which, as I just showed you, often ends up being a lifelong drug or hormone, and you don't want to have somebody on a medication lifelong for a temporary problem. Okay, so here is what my patient in clinic is hoping, and that is that her mild hypothyroidism is causing the symptoms that she is in distress about. Unfortunately, multiple cross-sectional studies, many of them now, and meta-analyses have shown that this is not the case. And the important thing about these studies is that the people with mild or subclinical hypothyroidism in these large studies don't know that they have mild hypothyroidism. So these are really big community-based, population-based studies where they measure TSH levels in thousands of people, and they do surveys for these symptoms, and there's no difference in the prevalence of the symptoms between the people with normal TSH and the people with elevated TSH. As long as they don't know they have the mild hypothyroidism. And that's going to be a theme that goes on and on through my talk, because as soon as you tell somebody they have mild hypothyroidism, you introduce a bias in terms of what they attribute their symptoms to and whether they think they might get better. Okay, so the other thing that my patient is hoping for is that if we treat her mild hypothyroidism, it will improve all of these symptoms. And unfortunately, again, multiple blinded controlled treatment studies and a recent meta-analysis, again, have shown that people with mildly elevated TSH levels, if you give them levothyroxine and you normalize their TSH levels, none of these outcomes change. And again, the important point here is that the studies are blinded, because if you give somebody open label LT4 and they go and read in the internet and they talk to their neighbors about all the great benefits of LT4, you're introducing a bias in terms of symptom control, which may or may not be a bad thing, right? If you can do it safely, but objectively and biologically, if you blind these studies, you don't see any significant improvement. Okay, so let's talk for a minute about this other distressing symptom she's got, which is often a major symptom in our patients with symptoms, and that is hypothyroidism-associated brain fog. And I was actually asked by the editor-in-chief of our flagship journal, Thyroid, which is an exciting read, by the way, if you ever want to get into that. I was asked to write a review article on hypothyroidism-associated brain fog. And I naively said, sure, I'll do this, and then lived to regret it, because it was probably the most difficult review article I've ever written. Fortunately for me, the editor put me in contact with a neuropsychologist who studies chemotherapy-induced brain fog, who helped me through this literature and helped me understand a lot more about brain fog. So what is brain fog? There is no standard definition, actually. The best definition we have is that it is a constellation of persistent and distressing symptoms, which usually include fatigue and depression, and always include cognitive dysfunction. And the main cognitive areas are memory and executive function. It is not specific to hypothyroidism, obviously. It's actually been described in a lot more detail in the oncology literature, as well as chronic fatigue syndrome, and now, as you're all seeing, in long COVID. In terms of brain fog described by our hypothyroid patients, the symptoms often predate the hypothyroid diagnosis by years. And to me, at least, that raises the question of whether it's related to the thyroid disease at all, or whether our patients have two things going on that are unrelated: mild hypothyroidism and brain fog for whatever other reason. So we don't know in this field whether the brain fog is related in some way to hypothyroid pathophysiology in the brain, or whether there's something else entirely unrelated going on. And part of the problem here is that there are essentially no rigorous studies in these patients who report brain fog, and no validated measures in the thyroid field for brain fog. So there are probably patients with brain fog in those big cross-sectional studies I just mentioned, but the studies were not specifically designed to enroll only those subjects, and so they're probably lost, or their data are diluted in the larger population studies. So until more targeted research is done, specifically in this patient population, the clinical approach is the same as in other other brain fog associated conditions, and that is optimizing diet, exercise, sleep, and stress reduction, which is often not what our patients want to hear because those things are hard. And one of the things I learned from my colleague is that in other fields, cognitive rehabilitation for brain fog, especially in the oncology field, is well established and effective. And so I think in the thyroid field, we should utilize this much more, referral for cognitive rehabilitation, until the point where we may have more targeted therapies. Okay, so I've now gone over my patient's priorities and what she is interested in. Now let's talk about one of my main priorities when I'm seeing her, and that is her cardiovascular risk. So this is I'm having trouble seeing here. This is a meta-analysis of over 500,000 participants from 35 observational cohorts. 5.7% of these people had mild or subclinical hypothyroidism, and the rest were euthyroid. And as you can see here in the overall analysis shown in the orange bars, both cardiovascular events and all-cause mortality was increased in the subclinical hypothyroid group compared to the euthyroid group. Sub-analysis showed that this was true specifically in the subgroups who had underlying high cardiovascular risk, or in younger patients, but not in older patients. And so I'm worried about this woman's long-term cardiovascular risk. Now, why would this come about only in younger patients? That's a little counterintuitive, because you might think, well, older people have a lot more risk factors for cardiovascular disease and mortality, so that should be increased there. Well, one of the explanations put forward is that they have so many other reasons to have cardiovascular disease and mortality that the small additional risk in mild hypothyroidism is kind of diluted out, whereas it's more prominent in younger people who probably have lower cardiovascular risk and have more years to have cumulative effects of mild hypothyroidism. And that may well be true, but I'm going to put forth another possible explanation for that data in younger versus older patients with my second caveat, and that is that the TSH reference range that the laboratory is telling us depends on age and antibody status. So let's spend a minute thinking about that. So this is a histogram over here of TSH levels measured here on the x-axis from 0 up to 6 in thousands of people shown here on the y-axis. And these are people with no known thyroid disease, so we think that they are euthyroid. And you can see that if this were performing like a regular old assay, that this should look like a bell-shaped curve, right? Because that 95% of people should be inside that bell-shaped curve, and then by definition, 2.5% should be below it and 2.5% should be above it. But that's obviously not what this curve looks like. And instead, what's going on is that there are a significant number of people ostensibly without any thyroid problems who have TSH levels in this tail that kind of trails upward. So why is that? Well, it turns out that there are two groups of people kind of hiding in here. And one of them is older people and the other is people with anti-TPO or anti-thyroid antibodies as sort of an incipient or perhaps a subclinical thyroid problem. And that's shown from this very large population-based studies as well as others, where I've graphed for you here the 97th percentile of the TSH. So this is the upper limit of the laboratory reference range that your laboratory will be telling you defines a normal versus an elevated TSH. And if you graph this by age, and you don't know the person's antibody status, that's shown in green, you can see that the upper limit of normal of TSH goes up, so that by the time somebody is 70 years old, a TSH of about 7 is actually normal. Well, some of these people, as I mentioned, could have very mild or subclinical thyroid disease. So let's subtract out the ones who have positive TPO antibodies, which is a sensitive marker for autoimmune thyroid disease. And if you do that and you graph the upper limit of normal here in blue, you can see that it does go down, but it still increases with age. So again, by the time someone is 70 or 80 years old, a TSH of 6 is normal. So the other thing that's going on in that big epidemiology meta-analysis I just showed you is that many of those older people who are labeled with subclinical or mild hypothyroidism with a TSH of 5, 6, 7 may not have any thyroid problem at all, and that may be why their cardiovascular risk is not elevated. Okay, so regardless of the TSH cutoff that we're using, what if we treat that mild hypothyroidism? What happens to cardiovascular shown on the left and all-cause mortality shown on the right? Okay, I'm going to ignore that. So this is another recent meta-analysis of over 21,000 participants. In this case, they all had mild or subclinical hypothyroidism, and some of them were treated with LT4 and some of them were not. And you can see that LT4 treatment over time reduced cardiovascular and all-cause mortality, again, only in the younger people. Okay, so let's get back to my case. My diagnosis was that she does have mild or subclinical hypothyroidism. It's persistent, and the TSH was 10 to 12, remember. It's probably Hashimoto's disease. That's by far the most common cause of mild hypothyroidism in the United States, and her little firm goiter was consistent with that. Given that she was young and she had a TSH elevation above 10, I recommended that we start low-dose T4. Now, why am I talking about a TSH of above 10? And that is because I didn't show on those previous slides, but the best data for cardiovascular risk and risk mitigation with LT4 is if the baseline TSH is in the 7 to 10 range. The data are much, much less impressive for the TSH of 4.5 to 7 or so. She had already gotten out of that range. But I also explained to her that her multiple symptoms were most likely unrelated to thyroid function. If they were related to thyroid function, they should get better on the LT4, but I needed to set reasonable expectations. And so they needed to be monitored. So what happened? We did start low-dose LT4. Her repeat TSH 6 weeks later was in the middle of the normal range, but she didn't feel any better. None of her symptoms had improved. She became angry at this and refused to return to clinic. So she's not alone in this regard. You may have seen this play out in your own clinics. About 10% of LT4 treated patients in big surveys report continued reduced quality of life and dissatisfaction with therapy. I and my colleagues in the American Thyroid Association looked into this in a little bit more detail with a survey we sent out online in 2017. We got over 11,000 respondents, and now obviously this is not a randomized or cross-section of patients. Probably certainly the ones who were more dissatisfied were more interested in filling out this survey. And in fact, we did a Likert satisfaction scale, satisfaction for therapy, and the mean score was only 5 out of 10. Over half of these patients changed care providers at least twice due to dissatisfaction specifically with their thyroid treatment, and some of them more than 10 times, which is kind of stunning. The major areas of dissatisfaction, no surprise, I've graphed them for you here, and you can see the majority of the respondents had exactly the same problems that my patient came to clinic with. So we've treated my patient with T4. She still has symptoms. Oftentimes then what happens is she'll come back to clinic and she'll say, well, I've heard that more thyroid hormone is better, so I want you to increase my dose. And that begs the question of whether altering thyroid doses in and near the reference range really affects these types of outcomes. And that hadn't been well studied at all in the literature. And so a few years ago, my colleagues and I at OHSU designed this study. We recruited 138 otherwise healthy subjects who had adult onset primary hypothyroidism. They had been on chronic LT4 with normal TSH levels. We brought them in and they completed extensive baseline tests of quality of life, mood, cognitive function, and metabolic function, exactly the issues that are often persistent. Now, again, a limitation of this study is that we didn't specifically target symptomatic patients. So I just want to point that out. After their baseline tests, we randomized them to one of 3 target TSH levels on LT4. Low normal, TSH of 0.34 up to 2.5, which should be the mean of the bell-shaped curve if TSH had a bell-shaped curve. High normal TSH, 2.5 to 5.6, which at the time was our upper limit of our laboratory reference range, and then even mildly elevated TSH with a TSH up to 12. So how did we achieve these TSH levels? Well, my colleague, Dr. Catherine Schuff, every 6 weeks, she randomized them to one of the 3 TSH target groups, decided on an initial LT4 dose to try and get there, and then every 6 weeks she measured a TSH level and adjusted the LT4 dose to again try and get them into that target TSH range. And then at the end of 6 months, we repeated the baseline tests. And as you can see, we were successful, whereas in the low normal TSH group, sorry, I'm having trouble with this again. Their mean LT4 dose was 1.5, which is kind of a full replacement dose, and that dose decreased into the high normal and mildly elevated TSH group, and the TSH target levels were reached: 1.34, 3.74, and 9.74. So the model was successful. Free T4 levels understandably decreased across the 3 groups, but T3 levels did not change. And that is actually pretty classic for mild changes in levothyroxine dose. You don't actually see a big change in T3. Okay, so what study measures or outcomes did we measure? They were extensive. They're shown on this slide. We did a number of validated measures of hypothyroid symptoms, quality of life, and mood. We did a lot of cognitive testing focused on the cognitive domains of memory and executive function, which is where our patient complaints are and where animal studies have shown prominent central nervous system effects of thyroid hormone. And then we did extensive metabolic testing as well. So cut to the chase, long story short, at the end of the study, there were no significant differences among the 3 groups, whether they had low normal, high normal, or mildly elevated TSH levels in any of these outcomes. So what we know from this study is that if you increase LT4 doses in patients who already have normal TSH levels, it does not help any of these outcomes. And again, the important point to make is this was a blinded study. So we avoided biases based on what patients knew they were taking. Okay, so that doesn't seem like it's a very good therapeutic option to push people's LT4 doses to try and reduce their TSH levels within the reference range. What about alternate thyroid hormone preparations? Patients read a lot about this on the internet, and they often come in asking about it. And what we're talking about here are really 2 flavors of alternate thyroid hormone preparations. We're talking about LT3. The brand name that's most common is Cytomel, but you can get other types as well. Or desiccated thyroid extract, shown here, which is basically ground up and purified beef or pork thyroid, and it has both T4 and T3 in it, but it has higher levels of T3 than are normally circulating around in our bodies. So why are we talking about T3? Well, the observation is that many LT4 treated hypothyroid patients have normal TSH levels, but they have low T3 levels. So kind of makes sense to say, well, let's supplement their T3. Although I note that if you study these patients, their T3 levels, in fact, are not correlated with symptoms. So that's a little bit of a caveat there. So this observation and the continued persistence of symptoms has led now to probably 14 or 15 blinded, randomized, controlled studies where some of a patient's LT4 is substituted with LT3. But unfortunately, those studies have not shown improvement generally in mood or cognitive function. So that's been disappointing. There are 2 additional studies of randomized controlled trials. One of them completely replaced LT4 with LT3, which I don't recommend. It's hard to do. And the other replaced the LT4 with desiccated thyroid extract. Neither study showed any difference in quality of life or cognitive measures. They both showed a decrease in weight by about 1 kilogram, 1 to 2 kilograms. So again, very disappointing. And again, remember, these are blinded studies. So we've taken the patient bias out of the equation. Okay, so that's disappointing as well. Let's so there are a lot of biological hypotheses and a lot of discussion and controversy in the thyroid field as to what is going on in these patients' brains to make them have continued symptoms, even though we think we're treating their hypothyroidism adequately. And I'm not going to go into those various biological hypotheses because they're still being studied and there are really no positive results yet. But I'd be happy to talk about those during the question phase if you want. Instead, I want to turn to some other data in the literature on what other factors might be going on in our patients. And the first thing to notice is that hypothyroid symptoms are common in both subclinical hypothyroid and in euthyroid subjects. And that's shown very nicely in this recent publication where these authors developed a survey of 13 symptoms that are very common in patients with overt hypothyroidism. And that's shown on the dotted line here, the prevalence of those symptoms. And you can see 80% of overt hypothyroid patients are tired, 60-some% have dry skin, and so on. And then they took this survey and they applied it to over 7,600 euthyroid subjects with no thyroid disease and with normal TSHs, and then 376 subjects with mild or subclinical hypothyroid disease. And remember, they didn't know they had it. So what you can see here is that the euthyroid subjects, shown in the dashed line, also had pretty high prevalence of these symptoms. So I think that's about 50% of them felt tired. I feel tired, so this is not a surprise. And you'll notice what's important here is that the subclinical hypothyroid subjects also had high rates of these hypothyroid type symptoms, and there were no differences in the scores between the subclinical hypothyroid and the euthyroid subjects, suggesting, at least to me, that we're looking at 2 unrelated issues in our patients. Okay, so if we don't think the symptoms are related to the thyroid disease, the next thing that patients ask us is, well, then what is going on? There's no research in the thyroid field about what is going on that could be explained by another diagnosis. So I've listed for you on this slide just some of my clinical observations from my patients. And that is that depending on what symptoms and what physical exam findings you might be finding, you may get clues as to other diagnoses. The most common, no surprise, is depression and anxiety, but there are also other possibilities that, again, you can get hints of if you see specific issues in their history or their physical. So some of the patients I see eventually get diagnosed with fibromyalgia, sleep disorders, celiac disease, vitamin D deficiency, and hypogonadism. Some of them come in saying, I've been diagnosed with adrenal fatigue. FYI, adrenal fatigue does not exist, but adrenal insufficiency does. It is rare, but occasionally I do pick that up. And so that leads me to my point that if you pay very careful attention to your patients and you don't automatically assume that all of their symptoms are due to their mild thyroid disease, you can sometimes pick up zebras, that it's not doing our patients any favors if we automatically label all their symptoms as being due to the thyroid problem. Okay, another point is that the prevalence of symptoms depends on self-knowledge of a thyroid disorder, regardless of the TSH level. And I've been implying this all along with my emphasis on the fact that the negative studies are blinded. So this is another study of almost 6,000 older community adults in the UK, and they did not know anything about thyroid disease. Most of them were euthyroid, but 168 did have a mildly elevated TSH. And you can see here again, same story, validated measures of anxiety and depression, no difference, just like the other study I showed you. In contrast, over 19,000 women in Norway, most had no thyroid history, and they had a mean TSH of 1.5. But about 1,100 of them did have a thyroid history. They were on LT4, and they had a matched mean TSH. And here, the ones that knew they had a thyroid problem had increased levels of anxiety and depression, again, suggesting a kind of a labeling bias. So third point I want to bring out is that hypothyroid patients have a bias towards higher LT4 doses. They've figured out from the kind of the public conventional wisdom that if some T4 is good, more T4 is better. And I want to show you some more data from my study. And this is at the end of the study, before we broke the blind, we asked subjects what dose they thought they were on. Were they on a higher dose, lower dose, or an unchanged dose from the beginning of the study? And then we compared that to what dose they actually were on. And as you can see here, they were not able to tell what we had done with their dose, which is good because that meant the study was truly blinded. But the interesting part is that we also asked them what dose they preferred, not knowing what dose they were actually on. Was it the dose at the end of the study, the start of the study, or no preference? And here we see a very different thing going on. If they thought we had increased their dose, 2/3 of them preferred that dose. If they thought we had lowered their dose, 96% of them preferred the dose at the start of the study. So people really don't want you to lower their LT4 dose, just completely independent of what dose they're actually taking. And finally, some thoughts about patient expectations. This is an online survey of over 1,000 hypothyroid patients. Most of them were dissatisfied with treatment. Most of them expected their symptoms to resolve very quickly. Significant number of them expected all of their symptoms to resolve and felt that they had not received adequate treatment from their primary care provider. They felt that alternative sources were better, and they expected to be referred to a specialist. Further investigating this area, there's a really lovely study just published about a month ago. It was a 68-country online survey in 5 different languages of over 3,900 hypothyroid patients. And they found that poor satisfaction with care did not correlate with the type of treatment. So LT4, combined LT4, LT3, desiccated thyroid extract didn't matter. What poor satisfaction did correlate with was no confidence in the healthcare staff, perception that the staff had insufficient knowledge, not given enough time to talk, not involved in decisions, feeling that the healthcare staff did not talk to them in an understandable way, and feeling they had not received enough information. So again, this is not a randomized sample, it is a biased sample, but it gives you some insight into what our patients are thinking about here. Okay, so with all of that having been said, how should we treat mild hypothyroidism? First, wait and recheck the TSH level in 3 to 6 months, because remember, it's common for this to be temporary. Treat persistent TSH elevations above that 7 to 10 cutoff, where we do think about cardiovascular events. That's where the strongest data is, especially in our younger patients, and use discretion for lower elevations. Start with low doses of LT4, recheck the TSH as usual, adjust the dose as usual, and aim for an age-adjusted normal TSH level. What is the target TSH level? And again, I'm thinking here now not of symptoms, but of the outcomes, long-term outcomes we care about. So this is really hard to read. So this is ischemic heart disease, heart failure, stroke, AFib, mortality, and fractures. And this is a study of newly diagnosed hypothyroid patients. They were followed for a mean of 6 years. And the reference range for TSH is shown on the vertical lines. And as you can see, if TSH was anywhere in the reference range, these long-term outcomes were okay. But the adverse outcomes started to go up with low TSHs or with high TSHs. So the most important thing once you decide to treat a patient is to keep the TSH in the normal range, adjusted for age, and anywhere in the normal range, at least for the things that as an endocrinologist I'm worried about long term, is okay. So just a couple more points, and this is obvious because you do this for all of your patients, not just for hypothyroid patients, and that is to set reasonable expectations, address their concerns in a respectful fashion, consider other diagnoses if the symptoms persist, and then if none of that works, I do admit that I consider a low-dose T3 trial because I can do it safely, and I am very clear with the patient that this is an N-of-1 experiment, and let's try it for about 6 months. Let's monitor the thyroid levels. Let's make sure it's safe and you're not having side effects, and see if you feel better. And if there's a bias or a placebo effect, okay, you know, if as long as we're not causing adverse reactions, that's okay with me. In my experience of people I start on LT3, about a third of them feel better, great. About a third of them don't, or even have side effects. And about a third of them feel better for a while and then come back and all their symptoms are back. So I do tell people that this is a time-limited experiment. And then just one final little asterisk here. Nothing I've talked about so far this hour applies to women considering pregnancy or who are pregnant. That's a completely different group. Okay, and finally, before we turn to hyperthyroidism, consider stopping LT4 in selected patients. This is a meta-analysis of 16 studies, and patients had either overt hypothyroidism, subclinical, or maybe not even a diagnosis of hypothyroidism at all, and they were all on LT4, and the LT4 was stopped. 37% of them remained euthyroid after the thyroid hormone was stopped. And that was much more likely if they had subclinical hypothyroidism or no clear diagnosis in the past of hypothyroidism. So rather than keep your patients on lifelong therapy when they may not need it, consider a trial in those patients off LT4. Okay, let's turn now for the last couple of minutes to a hyperthyroid case. This is an 86-year-old woman, persistent suppressed TSH now, no symptoms of hyperthyroidism, which 86-year-olds don't usually have symptoms, but a very significant past medical history of aortic stenosis, hypertension, diabetes, hyperlipidemia, a stroke, and mild dementia. And those are her medications listed. On exam, she's thin and elderly. There are her vital signs. She has an enlarged multinodular thyroid gland, and there's her aortic stenosis murmur. She has normal deep tendon reflexes, a mild tremor, and here are her thyroid function tests: suppressed TSH, normal T4, normal T3, by definition, mild or subclinical hyperthyroidism. Here's her radioactive iodine scan confirming a toxic multinodular goiter. Last caveat. Like temporary increases, temporary decreases in TSH are common, shown here, that if you get either a suppressed or a low TSH and you follow it over time without treatment, a significant number of those resolve on their own, probably for the same reasons that I mentioned earlier. And again, it's usually best to repeat the TSH before you embark on an evaluation and treatment. And in the case of my patient, she had had suppressed TSHs actually for a number of years. Okay, So what do we care about in my patient? Well, remember, she's got mild dementia and thyroid hormone affects the brain. And so there's been a lot in the literature as to whether mild hyperthyroidism increases the risk of dementia or cognitive decline. And that was settled by a recent meta-analysis, individual participant level of over 38,000 older participants. And they actually looked at all the different kinds of thyroid dysfunction, and there was no association between any thyroid dysfunction and cognitive function or dementia risk. And I've just highlighted what we're talking about right now, the subclinical hyperthyroid risk. So her dementia is probably not related. However, I am worried about her heart. This is a participant level meta-analysis of over 50,000 participants, followed for almost 9 years. 4% of them had subclinical hyperthyroidism, and those patients or subjects had increased all-cause mortality, cardiovascular mortality and events, and atrial fibrillation. These risks were higher if the TSH was suppressed rather than just low. And finally, we worry about bones in hyperthyroidism. So again, this is a meta-analysis of, in this case, over 300,000 participants. And they were older, and they were followed for a mean of 3 to 20 years. And those who had mild hyperthyroidism had increased risks of any fracture, hip, spine, and non-spine fractures. And again, this study did not look into, but other studies have reported that the risks are greatest if the TSH is suppressed. So back to my patient, I diagnosed her with mild hyperthyroidism due to a toxic multinodular goiter. I started her on methimazole to normalize her TSH level and protect her heart and bones, and on follow-up over a number of years, advancing dementia, but stable cardiac status. So how should we treat mild hyperthyroidism? If they're on LT4, lower the dose. That's easy. Otherwise, make sure that the patient doesn't have non-thyroidal illness to explain that low TSH, because that should not be treated. Then wait and recheck a TSH level after 3 to 6 months, because remember, temporary decreases are common. And then if you do think that you need to treat, you have to determine the etiology of the hyperthyroidism and tailor the treatment. So this will be my last and most important take-home point, and that is that no matter what degree of hypo or hyperthyroidism you diagnose in your patients, the most important thing to remember is that if the TSH levels are either high or low, patients have increased rates of adverse outcomes. We know from a lot of studies that overall mortality is increased in undertreated hypo or hyperthyroidism of any degree, and that cardiovascular events are more common in undertreated or overtreated hypothyroidism. So the single most important thing once we decide to treat any type of thyroid disorder is to try and keep the TSH in that reference range. I'm going to stop there and acknowledge my colleagues and the staff of our Clinical Research Center for those experimental studies I showed you. Thank you so much for your attention, and I'd be glad to answer any questions.
Dr. Samuel, thank you for an excellent talk and a great tribute to Dr. Kammer. I have some questions online, and we'll go ahead and field questions from the room here as well. Dr. Gilbert.
Thank you. You taught me a lot, as Dr. Kammer always did as well. One Trivial Pursuit question. The Iowa gambling panel or questionnaire.
Yeah.
I didn't think of gambling as executive function.
Right. That is a really interesting task that my cognitive neuroscientist colleagues taught me about. So the Iowa gambling task is considered more of a real world test of executive function in terms of judgment, which is very hard to measure with our classic cognitive tests. And in this task, subjects have on the computer 4 decks of cards, and they have some money that they can gamble on which card from which deck they're going to turn over. And what they don't know is that some of the the decks are either high risk, high reward, low risk, low reward, low risk, high reward, and so on. And people who exercise good judgment tend to figure that out over the multiple attempts, and they tend to start only going for the low risk, high reward deck. People without good judgment tend to lose money on that. So it's that part of executive function that is testing.
Real quick, the fact that some of the hypothyroid patients have Hashimoto's. So do you routinely check thyroid antibody as part of your evaluation, and how does it influence?
Yeah. That's a great question. I do not, because I find that it does not affect my management. I go by the TSH levels, because if somebody has positive antibodies and a TSH of 5, I'm going to follow them, but I'm not going to treat them. If they have negative antibodies and a TSH of 10, I'm probably going to treat them. The exception to that is women trying to get pregnant, or who have miscarriages, because in those women, thyroid autoimmunity is thought to play a role. But I do not check anti-TPO antibodies that often, because frankly, it doesn't, I mean, it's cool to know what they've got, but it doesn't change my treatment.
Hey there, great talk.
Thank you.
I was wondering about the study that you guys did, and studies like it, where we're treating patients who are within the normal range, or subclinical hypothyroidism. Did we measure any increase or appreciable increase in harms with increasing the?
Yeah, that's a great question. So there were no adverse effects and no more dropouts in one group than in the other group. So as far as we can tell, being very careful to clamp these TSHs, we did not see side effects. That is also true in most of the other studies I've shown you. Caveat number one here is that none of these studies go on for years. So ours was a 6-month study. That's actually one of the longer studies in the literature, because these are super expensive. That study I showed you was a 5-year NIH study at about $400,000 a year. So we're not going to do a lot of those studies. So that's the caveat. The second caveat is that some of the studies of specifically of LT3 do show some adverse events, especially if you push the T3 dose on the higher side. And I've seen that in my own practice, where people will come back and say, yeah, I took the T3 at 8 o'clock, and by 10 o'clock, I couldn't get on the treadmill because my heart was pounding. So T3 can be a little futzy that way, but in general, no.
Hi, Mary. Claudia Leonard back here. Nice to see you. That was great. So I have a practical, easy question, which is, when we take people off their thyroid medication, do we need to taper, or can we just stop it?
You can just stop it, because you can do that safely, because the half-life of T4 is, did you say T4?
T4. Yeah.
T4, okay. The half-life of T4 is so long that it will naturally, gradually go down. But I do sometimes taper it, because if my patient is really skittish and they're like, oh, no. So I'll say, let's try you on half dose for 2 or 3 months. So I do it based on patient preference, but there's no reason that you can't just stop it.
And then my second question is, someone who doesn't like to take pills, the cardiovascular risk in young people, looks like that relative risk was pretty small.
Yeah.
I'm assuming that the absolute risk is tiny.
That's correct.
Do we have any numbers on that?
Yeah, I don't have them off the top of my head, but you're correct. The relative risk, although it is statistically significant, is not as huge as we see in other studies where it's double, triple, quadruple the risk. And so I think you can safely not treat patients, especially with very mild TSH elevations, and then just follow them carefully. Yeah, absolutely. That's an excellent point.
Thank you. I'm going to go ahead and draw from a question online here. Have you found any effects from patients who supplement with zinc or selenium? And would you check the levels of these minerals in people who are supplementing?
So to answer the second question first, no, I do not. The zinc and selenium issues are interesting in that, especially for selenium, there are a number of studies out there now to suggest that selenium, so selenium is a metal, an element that is essential for thyroid gland function, not necessarily just thyroid hormone production, but thyroid gland function. And we don't have a lot of selenium deficiency here as opposed to in other areas of the world. But there are studies that show, maybe half a dozen studies out there, that selenium can actually lower thyroid peroxidase antibodies and maybe cool down. It has an anti-inflammatory action in the thyroid. And that has led to some interest in, well, maybe we can treat mild hypothyroidism with selenium instead of with thyroid hormone. And there isn't any data on that because the people who were studied either didn't have TSH that went down or they were already on levothyroxine. So we don't actually have any hard data on that.
Great, thank you so much. It's a familiar topic I was certainly not familiar with. Want to acknowledge that we are right at the top of the hour at 9 o'clock. Thank you again for your time, your teaching, your expertise, Dr. Samuels.
Thank you.